Today you will learn methadone is a treatment option for opioid use disorder. You can start methadone in a patient who has opioid use disorder who may or may not be in withdrawal.
The starting dose from the ED is 30 to 50 milligrams. And when you start it, you need an opioid treatment program to send the patient to because you cannot prescribe it.
Patients using methadone with acute pain issues can and do still experience pain, so you may need even more opioids to treat the pain. But try alternatives first, just like you would in everyone. Welcome back to eImpulse.
We've spoken several times over the years about Suboxone or buprenorphine and medical treatment of opioid use disorder.
But our colleague, Dr. Daniel Hernandez, pointed out that we jumped to the new fancy medications and missed talking about the original amazing treatment option for opioid use disorder, methadone.
So Daniel made a solid point, and we brought him into our studio today to talk about methadone.
Dr. Daniel Hernandez is an assistant professor of emergency medicine at UC Davis. He's part of the Division of Addiction Medicine, and he works in an opioid treatment program.
Daniel, welcome to eImpulse.
Thank you. Thank you for having me.
Daniel, there's some basic treatment options out there for opioid use disorder, right? And methadone is one of them, but remind us really quickly, what are the kind of pillars of treatment?
Yeah, so let's start by saying that there are 3 FDA-approved medications for the treatment of opioid use disorder, and that is methadone, buprenorphine, and naltrexone.
Perfect. And methadone, we have not spent much time talking about here. Remind us, what is methadone and who is it right for?
Methadone has been available for many decades for the treatment of opioid use disorder. It's a long-acting, full agonist opioid. It's also a Schedule II medication, which means that we as emergency physicians are allowed to use it in the emergency department and on the inpatient side, but you're not allowed to prescribe it to patients for the treatment of opioid disorder. For this reason, patients actually have to follow up on an opioid treatment program or an OTP, and that's per federal regulations.
So tell me, how does methadone differ from buprenorphine in terms of treating opioid use disorder?
Yeah, so methadone is highly effective to control withdrawal symptoms and cravings for opioid use disorder. It's similar to buprenorphine in that way. One big difference, however, is that you don't have to be in withdrawal to start methadone. Initial dosing and up titration can be a little bit slow, and it can take several days to weeks to reach a dose that can match the patient's level of tolerance and therefore fully control their withdrawal symptoms and cravings. For instance, initial dose is typically 30 to 50 milligrams on day 1, but it is increased by 10 milligrams every 3 to 5 days since it takes this long to reach steady state serum levels.
Let's take this from my case perspective. I have a patient that comes into the emergency department. Let's say that they're 19 for simplicity's sake here, and they have been using fentanyl and want a treatment option. I have a clinic that has both methadone and has buprenorphine. How do I have that conversation with them about deciding which medication to start?
So I often get asked which medication is better. Is methadone better than buprenorphine, or is buprenorphine better than methadone? And I think that's a really hard question to answer. I think depending on where you look, you'll find that maybe some literature will say that methadone is better on certain outcomes than buprenorphine, or the other way around. And, I think that if you have access to a methadone clinic in your community and your patients don't have any barriers to transportation, let's say, in that case, the best medication is the one that they are going to take, right?
Yeah, fair enough.
I think one of the best things that we can do for these patients as emergency physicians is know the difference between both of them, know the pros and the cons for each of them, and then just have the patient decide which one is better for their goals, which one is better for their lifestyle.
So you mentioned the advantage of the patient not going into full withdrawals in terms of starting methadone, which is maybe a little bit different than buprenorphine. So if I came to you in the ER with this hypothetical patient that Julia mentioned, how would you have that discussion about which one is a better medication to start?
Yeah, that's an excellent question. So I actually have this conversation every single time that I talk to a patient that is interested in starting medications for opioid use disorder. What I usually tell them is that both methadone and buprenorphine are very effective and safe for the treatment of opioid use disorder, and that we're targeting their withdrawal symptoms and their cravings with both of those medications. However, the initiation process looks a little bit different for both of them. Like I said earlier, patients don't need to be in withdrawal in order to start methadone. But having said this, it is relatively contraindicated in those patients that are sedated from either other opioid use or other substances such as alcohol or benzodiazepines. Other contraindications to be aware for both patients and prescribers include respiratory depression, severe liver disease, or if your QTc is over 500 milliseconds. Routine EKG is not necessary, however, for starting doses unless the patient has other risk factors such as heart disease or known QT prolongation in the past. At the methadone clinic where I work at, we actually don't routinely check EKGs unless a patient exceeds over 120 milligrams of methadone. So for regular starting doses, which is usually 30 to 40 milligrams of methadone, you don't necessarily have to do it unless you have another reason. Patients that do really well on methadone are those patients that have a high tolerance for opioids, especially those that are using fentanyl. And for patients that maybe in the past have not tolerated buprenorphine, or those patients that are not going to tolerate that withdrawal period that is required for starting buprenorphine.
Those all sound good and very reasonable reasons. But, we've been talking about buprenorphine as a in-the-chair kind of medication that they can take home with them. And these doses can easily be adjusted as an outpatient. Methadone, I can't prescribe them methadone to go home with, right? Like I can't give them a few days supplies like I can with buprenorphine, right?
Correct. So methadone is a Schedule II medication, and per regulations, you're only allowed to give prescriptions for the treatment of opioid use disorder for Schedule III medications, which that is only buprenorphine. In the case of methadone, patients actually have to follow up at an opioid treatment program, also known as an OTP or also known as methadone clinics, where the patients have to go for the first time to do a full intake, where they do a full history and physical exam, focusing on their drug use. They are also tested for other drugs. They are tested for TB and other STIs. They get set up with a counselor, and they usually get dosed for the first time at that methadone clinic. This process can take anywhere from 1 to 2 hours on day one. And then after that, the patients are just coming in for their dosing, which takes just a few minutes.
So is this something that I can actually initiate from the ED?
Yes, and I think as emergency physicians, we should, because it is a very safe medication, like I said. There are some federal regulations on the starting dosing. So for example, at the OTPs, the starting dose is not to exceed 50 milligrams on day one. From the emergency department, and someone that has high opioid tolerance, starting anywhere from 30 to 40 milligrams is very safe, especially if they don't have any of the contraindications that we talked about, including sedation or other contraindications like liver disease or prolonged QT.
So I would then write them for that dose in the ED, and then I would have to liaise with our substance use navigators to make sure that they had follow-up in a clinic the next day.
Yeah, so what it normally looks like is after you have a conversation with the patient between the differences of methadone and buprenorphine, and they decide to start methadone. If the patient doesn't have any contraindications, we normally start him at around 30 milligrams. And they get discharged with instructions on how to follow up at a methadone clinic in their community. There are some situations where the patient might not be able to follow up immediately at a methadone clinic. For example, some methadone clinics have certain availability on which days they can bring in new patients for intakes. Some methadone clinics only do intakes from Monday through Friday, let's say. So if you meet one of these patients on a Friday, and you're able to give them 30 milligrams of methadone, they might not be able to follow up at the methadone clinic until 2 days after that. But there's actually a regulation that's called the 72-hour rule, where you can actually have the patients come back to the emergency department for up to 72 hours, and they can receive their dose from us while they're awaiting their intake time the following business day.
So for 3 days in a row, we can give them their medications.
Correct. Yeah. For those patients that we start methadone for the first time, we are able to dose them for up to 72 hours. But there are some circumstances, you'll meet patients that come in because their methadone clinic is already closed, or they're coming in a day that their methadone clinic is fully closed. Or you might actually run into a situation where you are seeing a patient that is in your emergency department. Maybe they're admitted and they're requesting their outpatient dose on a patient that's well established already, and they want to get their regular dose in your emergency department to avoid withdrawal symptoms. You are actually able to dose those patients for up to 72 hours if they're being discharged, or you can continue to dose them while they're inpatient as well.
Walk us through, what are some of the downsides of methadone? I can already hear having to go to clinic every day can be a downside, but what are some of the other downsides of methadone versus buprenorphine?
First of all, there are some communities out there that don't have any access to an opioid treatment program. There's no methadone clinics around you. And so if that is the case, this is probably not a medication that we should be starting in the emergency department. One of the other downsides is that you actually have to go to a methadone clinic every day, at least initially. So the way that this usually works out is the patient will go to a methadone clinic on day one. Like I said, it takes a couple of hours to get everything started. And then from there, you go and do daily dosing. But after a certain amount of time, and that's usually within 1 to 3 months, patients can actually start gaining all these benefits in the form of take-homes, where, sometimes if they go to the clinic fairly regularly, their UTOX is starting to not show any other substances, they can actually start getting take-homes. And that goes anywhere from a couple times a week to up to 28 take-homes, where patients are coming into the clinic once a month. That's a very stable patient, but I have a lot of patients that come in only on Mondays or only on Tuesdays, and they dose the day they come in, and then they get 6 little bottles with their daily dose. So I think it's something that is not commonly known, but methadone clinics actually have a lot of flexibilities. And for a patient that's well established, they're able to have a normal life and go back to their job because they are only coming in once a week or sometimes even once a month. And, to the other point of patients are still going to be using opioids while they're on a full long-acting opioid, it is a concern that we have, right? We don't want patients that are on an opioid already to get overly sedated or even worse, cause respiratory depression. But, the reality of opioid use disorder and the reality of how slow sometimes we have to go with the methadone as an outpatient is that there's a lot of patients that are going to still use fentanyl while they're up titrating their methadone to a dose that is comfortable for them, right? Let's say that we have a patient that is started at 30 milligrams of methadone on day one, but they use about 1 gram of fentanyl, which is a good amount of tolerance. They might not actually feel comfortable, and they might still be using fentanyl up to the point where they get to, let's say, 100 milligrams of methadone. But while the patient is using this methadone and fentanyl, they're usually decreasing the amount of fentanyl by a good amount. And that is a huge advantage that we have, right? We have patients that are using less and less. And in opioid use disorder, less fentanyl means less chances of overdose and more chances that they're going to be regaining their functionality in their lives.
Yeah.
So they sort of self-titrate.
Correct. Yeah. I think that this is true for the majority of the patients. I hear a lot that they will get started on methadone, still have withdrawal symptoms. And how do they know how to treat their withdrawal symptoms? They continue to use their regular opioids, right? And then after some time, they start using less and less and less until their methadone is at a good, comfortable dose. And then they can stop using opioids. The other point to that is that recovery doesn't necessarily mean abstinence, right? Abstinence is great for some patients, but for other patients, using less is their way of just regaining some of their life back and some of their functionality. And so for a lot of patients that are on methadone, or even some patients that are on buprenorphine, they're continuing to using fentanyl or opioids, whatever they were using before, but to much lesser degree. And so a lot of the times that is a huge win for us in addiction medicine.
Okay, let's go back to my 19-year-old. They decide they're sold. You have a clinic for them to follow up in. They want to do methadone. How do I decide whether I'm doing 30 or 50 milligrams? Like, how do I figure out that first dose?
I think from the emergency department, so our starting doses are usually 30 to 40 milligrams. And on the outpatient side, we're capped at about 50 milligrams on day one. I would say for someone that doesn't meet any contraindications for methadone and has a known high tolerance for opioids. So, anyone that is really using fentanyl or opioids on a regular basis, 30 milligrams is probably a good starting dose. If you have someone that is elderly or that is on other sedating medications like high doses of gabapentin, let's say, or they're taking prescribed benzodiazepines, for example, that's someone that would maybe start a little bit less, but I would say 30 milligrams is very, very safe.
When we talk about bup starts, we talk a lot about the COWS score to sort of make sure that people are in enough withdrawal to start it. Does that come into play for methadone?
Not necessarily. So the COWS score is used to grade the severity of opioid withdrawal symptoms. And that is important in buprenorphine because we want to make sure the patients are in enough withdrawal so that we are not starting someone on buprenorphine and then they experience precipitated withdrawal. And precipitated withdrawal happens when you still have opioids in your system and when you give that partial agonist that has a really high affinity for the opioid receptor. In the case of methadone, let's keep in mind that the methadone is a full agonist, so you actually don't get that same effect. And it's more important to make sure that you're not giving methadone to someone that is sedated in the first place. But you don't necessarily have to be in withdrawal. Most of the times, patients will be uncomfortable when we're starting methadone, but you just don't want them to be sedated in order to avoid that oversedation and respiratory depression.
With the buprenorphine, we can adjust that dose if they are in withdrawal until they feel comfortable. Do you watch them after giving the 30 milligrams of methadone and readjust if you need to based off of their symptoms?
Yeah, that's a great question. So in the case of buprenorphine, one of the other advantages is that you can titrate that dose up to our usual maximum, which is 32 milligrams. And you can do that from the start. In the case of methadone, when you give 30 milligrams, that might not be enough to control their withdrawal symptoms, but most certainly the patient will feel better. Methadone takes about 2 to 4 hours for its peak effect. And so when you give someone 30 milligrams of methadone, it can take that long in order for you to know how their full effect will be. For that day one, what we normally recommend is to give 30 milligrams and discharge home. You don't necessarily have to ops the patients if they don't have any other contraindications, so they're not sedated in the first place. But it is safe to give another 10 milligrams on that day one after about 2 to 4 hours, which, a lot of the times we don't necessarily keep patients that long if that's the only reason why they're there.
So talking about these patients who come in who are already on methadone, what if someone comes in with a femur fracture and they're already on daily methadone? How do I treat their pain in the ED?
I love this question because there are so many misconceptions that I encounter on patients that are on methadone that are coming into the emergency department or to the hospital with any acute painful condition. One of the main misconceptions that I see out there is that methadone is providing analgesia for those patients that are coming in with acute pain. And I think this comes from not wanting to oversedate our patients or cause respiratory depression on someone that already has a long-acting opioid on board. However, it is important to keep in mind that this patient's methadone is just taking care of their quote-unquote baseline opioid needs, right? That means that it's only enough methadone to prevent them from having withdrawal symptoms or cravings. And this is because after chronic opioid use, you have a lot of many different changes happening in your brain, which include downregulation of opioid receptors, for example, and opioid activity in general. So methadone is taking care of this gap in a way, right? These patients have a really high opioid tolerance and therefore even need higher doses of opioids than you would with an opioid naive patient. So my rule of thumb is usually to give more opioids than you would normally give an opioid naive patient. For example, if you give someone oxycodone 5 milligrams as your starting dose in someone that's coming with acute pain that's opioid naive, I would probably give about 10 milligrams in someone that has known opioid tolerance because they're on methadone. Or if you would give someone hydromorphone 0.5 milligrams IV, then I would probably give them about 1 milligram. And this is just an example. Obviously you want to use your clinical judgment when you're doing this. These patients also benefit greatly from multimodal pain control. So things like NSAIDs, acetaminophen, gabapentin, muscle relaxers, and pain dose ketamine, just to name a few, are very good options for these patients. And also, just as important, I think another misconception that I really want to address here is that I sometimes encounter this misconception that patients in acute pain are going to be worse off or going to feed their addiction if we give them opioids, right? Because they maybe have all this other medical problems from their opioid use in their first place. And, to that, I would say that patients typically do even worse when you are having acute pain or you have acute withdrawal just kind of sitting in your ER. This often leads to patients in recovery having cravings for return to use if they're sitting there with acute pain or withdrawal, or even worse, they are using illicit opioids in the hospital because we are not providing them with that full agonist opioids that they maybe need. Or maybe they leave against medical advice to use opioids and not finish the full treatment for their primary chief complaint that they came in. So, when this happens, it's a huge disservice to these patients. So treating pain, treating withdrawal symptoms is a very important part of this patient's care.
So I'm not going to set them back in terms of their opioid recovery journey by treating their pain with opioids in that acute phase.
No, not at all. I think that having a patient sit there with acute pain, having a patient sit there with withdrawal symptoms is probably going to do worse than us addressing that with the full agonist, right? Keeping in mind that methadone is only providing that baseline need of opioid activity in the brain and not necessarily any analgesia.
Yeah, that's a good point. Daniel, what do you see are some of the biggest challenges to ED-based methadone care?
I think, honestly, the biggest challenge that I see is that we might not be thinking about all the options that we have for opioid use disorder. So I think in the emergency department, we've gotten so good about thinking opioid use disorder and thinking buprenorphine, which is great. I think, I haven't said this before, but I think if someone has both options and they're willing to do buprenorphine, it's usually my first option for the patients as well. But I still go through the differences and just let the patient decide at the end. I had recently had a patient that was getting admitted to the hospital for a new workup of heart failure. She was a 20-something-year-old female that also had a history of stimulant use disorder. And I got a call to try to start this patient on buprenorphine. And, the patient was open to the idea of doing buprenorphine, but she was really afraid of precipitated withdrawal, and she also couldn't tolerate withdrawal symptoms. She could not wait those, 24 hours that we normally wait at least for buprenorphine. While she was waiting, she ended up using in the hospital. She ended up leaving AMA. She came back the following week, had the same situation, left AMA, could not tolerate buprenorphine induction, and therefore couldn't get her treatment for heart failure. She went to another hospital, left the hospital, came back. I saw her again, and this was her fourth or fifth visit for the same. She was already admitted up in the floor, and I got a call because she was waiting for buprenorphine initiation, and she was thinking about going outside and using the last little bit of fentanyl that she had with her, or she wanted to leave AMA. And I sat down with her and I said, we've tried this so many times, and I don't think we've actually talked about methadone. And I talked to her for a little bit. I told her there's no risk for precipitated withdrawal. We didn't have to wait for her withdrawal symptoms to get worse. And she actually ended up handing me the last bit of fentanyl, which I disposed of. And she tried methadone. She felt immediately better. And she actually ended up staying for about 2 weeks and got her full treatment and workup for her heart failure. So that was a really successful story. And I think that just like that patient, there are so many other patients that might not know the full spectrum of the options. And I think part of our job is to make sure that we know the differences. We know how to counsel our patients about which option might be fitting better with their lifestyle and their goals.
I like that.
That's a great example of a patient that would benefit from methadone, maybe more than buprenorphine. Daniel, final question here. Anything we've missed, and then also any resources or tips for people who may want to start methadone on specific patients from their ER, but have never done that before? Because I think that's a lot of us.
Yeah. One of the other things that I get asked a lot as well is, once you start methadone, once you start buprenorphine, do patients just need to be on that forever? Because even patients, no one wants to be on a medication forever. It's a big commitment, and I think, unlike many other medical conditions, the treatments for substance use disorders are very patient oriented. And we focus on how we can meet the patients where they're at, and we focus on what works best for this specific patient, right? Everyone is so different. Substance use disorders affect everyone. They don't discriminate. And so everyone is going to have different needs and different resources. And, the other thing is that we probably in the emergency department see the worst of this patient's conditions. Patients are coming in with acute withdrawal. They're coming in acute pain. And on top of that, they might be having other needs. And it's really hard to see the other side of addiction when we're in the emergency department. I'm lucky enough that I work in an outpatient clinic where I follow up these patients after, days or weeks or months or years after they got started on these medications. And I can tell you that, these medications work. They're very effective. They help people turn around their lives and regain this functionality. And there's really nothing more satisfying than seeing, this often young people with no other medical conditions just turn their lives around. And it's through the help of, not only medications, but other things in the community that they can access. So, I think it's important to keep that in mind because, these patients get better and these medications are highly effective. They're very safe and we should be using them in the emergency department. And one of the resources that I like using a lot on shift and also just referring my colleagues to is this website called California Bridge. The actual link is bridgetotreatment.org. But in there, you can look at their resources and trainings tab. And you'll find a lot of information on how to start patients on methadone, how to start patients on buprenorphine. A lot of the stuff that I talked to in here is going to be, in greater detail, which you can easily use on shift to help these patients.
Well, that's a great spot to stop. Thank you so much, Daniel, for sharing your wisdom with us. And I love that ending on a moment of hope and resources. You can do this.
Thank you so much for being here, Daniel. And thank you to our department for training so many specialists like you so we can explore all of these treatment options.
And thank you to OM Productions for making this all happen.
So until next time, stay curious, stay inspired, and stay tuned.
The opinions shared on EM Pulse are those of our hosts and guests. They don't necessarily reflect the views of UC Davis Emergency Medicine, UC Davis Health, or any of their parent organizations.